All right, thank you guys. My name is DJ Apakama. I am an assistant professor of emergency medicine, also a data scientist. I work at Mount Sinai Hospital in New York City. Today, I want to talk to you about bias and emergency medicine AI. I have no disclosures, unfortunately, but do have some goals for the talk, which is first and foremost, I want to raise awareness about AI bias and provide a framework for you to kind of understand what that bias is and how we can potentially mitigate some of those things. Share evidence-based insights on the impact of bias, which thank you again for that talk because you set me up brilliantly. And then empower emergency physicians to critically appraise AI research, which there will be lots coming, and I think we all have to kind of join in on the task of going through it. So what is AI and what is AI to you? It means different things to different people. Let's start with this, which is an image that was generated by AI with the prompt, a call to action for emergency physicians to be wary of AI bias. And I think it's interesting just because very focused on the screens. Some of the things that you see there are actually not, like this lady here is probably not human. So I'm gonna go back, there you go. The top corner there, not really sure that's human. But overall, the AI thinks that we're kind of tuned in. I don't see an actual robot here. It's very interesting. But AI basically is any system that can start to imitate or even sometimes surpass human abilities in the realm of decision-making, reasoning, logic. And they can do this from past experiences. So how does AI work? Well, because we're at an emergency medicine conference, we'll use an emergency medicine analogy. So just like it works like training a resident or an emergency physician. We're talking about in the real world. Well, we start in the real world with our real world biases and beliefs. So we'll start there. Well, AI starts with a real world problem, something that you want to fix and solve. We learn from our patients. An AI model is going to learn from data. We go to residency to train. An AI is going to have a very similar training process. And then when we graduate and we go into clinical practice, we're using our gestalt. That's a lot like making the predictions. When we want to iterate and continue to that to get better at our practice, it's like CME. So I want to give you these tools now at the beginning. That's just questions to kind of investigate the research in front of you to see whether or not it's harboring any biases, any latent biases. And there's one question for each specific stage of developing an AI model. So we're talking about real world, we're going to simplify this question to essentially who is represented in this data in the real world? Were all the stakeholders taken into account when we design this problem? For data, well, who's collecting the data, who's included in the data, and how did we handle the data after we collect it? The AI model itself, well, was it validated in many settings or was it just one? Was it internally validated or externally validated? And then last but not least, is this a black box? Is the AI just telling you something and you have to follow it? Or can you understand how it came to those conclusions? So when we talk about AI in emergency medicine, there's a lot of promise, and the promise is at almost every stage we can think of, whether it's pre-hospital, triage, when we're actually working the patient up in the ED, or at disposition. There are a lot of possible advances that we could see AI helping out with. And when we look at the literature, indeed we do see some of these advances, whether or not we're talking about faster recognition of out-of-hospital cardiac arrests, or faster triage, better triage, making more accurate determinations about who's going to deteriorate in an ED, or actually helping us out with documentation. All of these things, when we look at the literature, AI is actually starting to show some promise. But the promise must come with an asterisk, that AI has a maturity problem. And what do I mean when I say that? Well, this was taken from the ICU literature, but it's very much so commonplace of all AI research in medicine. And what it shows is, for those of you in the back, I'm just going to kind of summarize here, but essentially we looked at 500 studies, that all having to use AI of some sort, and the vast majority, 85.2%, are retrospective, internally validated studies. So this is very poor evidence as far as we're concerned. And then for randomized clinical trials, randomized clinical trials, we have only 1% of trials. So it's actually 5. When we look at data size, the data set size, which we know we want big data, that's right there in the title. Well, the vast majority of the studies that we're looking at for AI are actually using small data sets or medium-sized data sets. The dark blue represents data sets over 100,000, very few. And then when we look at how AI is progressing, well, what we see is that there's a lot of models, there's a lot of potential, there's a lot of people suggesting things that could work, but we have yet to see that translate into clinical practice. So there aren't a lot of models that are actually determining clinical outcomes at this time, despite the progress that we see. So all this basically comes together to increase the risk of overall bias. But what I really want to talk to you today is about how that now entrenches our societal real-world biases into the model and what that looks like. So again, sources of bias, we're going to come back to this model. We'll start in the real world, right? Because AI is not built in a vacuum, and bias can creep in at any step. So when we're talking about the real world, we just had a fantastic lecture that laid out that we still have problems in racial disparities, or with gender disparities, or with social demographics, right? Those are all systemic issues, and you may say, those have nothing to do with me. Well, let's talk about one that does. Documentation bias is literally your record of what was said. And when we look at it, documentation bias doesn't happen randomly. It overwhelmingly occurs in marginalized communities at a higher rate and seems to have effect on patients' trust in the system, but also the outcomes of pain, medication, and time to treat. So when we're talking about the stigmatizing language, well, what does that look like? Well, it can be anything that's questioning credibility, disapproval, stereotyping the patients, portraying the patient as a difficult patient, or unilateral decisions. And this is important because, as we just said, however you describe that patient, although it might have been momentary, fleeting, maybe you were upset, maybe the patient was upset, that can be logged in the chart and follow that patient for a very long time, long after you've forgotten about the interaction, right? And this is a bias that, again, is solely based on our shoulders. It's not society doing this. When we talk about the data, well, data can also be biased too. This is a study that looked at persistent anti-Muslim bias in large language models. And so it's a little bit old. They use ChatGPT 3, but I think it's interesting to note and go through. And what they did was they essentially gave the model an autocomplete test. So they gave it the first part of a sentence and said, how would you finish this? And what you can see is the first part of the sentence is, 2 Muslims walked into A. And I won't, if you can't read them back here, very offensive stuff is written down here, which I won't give words to, but you see how the model was completing it. And when they looked at overall, this is a 75% violent auto-completion rate for ChatGPT. And okay, so that's one religion, but when they looked at other religions, we see other concerning associations, whether or not we're talking about the Jewish faith, Sikhs. Christians actually had some slightly affirming language, as did Buddhism, but again, this is overall, these are the major religions in the world, and we're seeing very large bias, and it's from the data. And why is this model acting that way? Is it because the model itself is racist, or the model itself has religious bias? Well, yes and no. The model was trained on the internet, okay? And so we know that the internet has a lot of the worst elements of humans in it, and that's exactly what the model is showing you. So aside from the data itself, where we get it from, just how we measured it or where we measured it can also put in bias. So when we look at the EHR, we know that the EHR, great for storing things like labs, your vitals, even notes to some degree, right? But what's not captured there are things that also matter, like social determinants of health, right? Like your living situation, your built environment. Not there, not captured. And we know that these things affect medicine. So when we're trying to build a holistic picture of our patients, we automatically know we're missing some stuff. This was a study that looked at patients who were suffering with diabetes across the entire health system, their blood pressure taken at different locations. And I love the study because it proves what I always think is that, people are a little bit more hypertensive in the ED than other locations. And exactly that. So if you could see, if you were trying to build a study based off this, and you were looking specifically at hypertension, well, the ED would be a great place to look, but that also might be a misleading place to look. So when we're talking about designing, we can also have issues with designing. So this was a study by Zaid Obermeyer, which looked at an algorithm that was meant to predict the care of a population, and it used cost as a proxy, which cost seems like a pretty straightforward metric to use. Unfortunately, it has its issues. So what we're looking at here is essentially the percentile of people, or the algorithm score that was given to both black and white patients, so black patients being in purple, white patients being in gold. And at the same level of risk score, you can see that black patients were ultimately sicker or had more medical comorbidities than white patients that were default to the program. So from that, they actually redid the numbers and they swapped sicker black patients with healthier white patients until this number balanced out. And you can see that the fraction of black patients that were in default into the program, well, there was a significant rise in it. When they looked at cost overall, and so this is kind of the crux of this, when they looked at cost, so A, there is no real difference between these charts. That looks to be about the same. And the problem is that when they looked again at the expenditures by race, what you're seeing is that we're systematically underspending on black patients across very wide margins, right? So while we can try to use cost and say, well, that cost should be a bias agnostic marker, well, cost, if we're automatically spending less on those populations to begin with, well, then the algorithm is going to perpetuate that. That's exactly what we see. And this is the last real world kind of bias example, but we're talking about when we go to make bias predictions. So a lot of people don't realize this, but a lot of AI research is done on public EMR data sets, which Mimic is probably the most popular one of those, but there are others. This study looked at 3 such databases that also have chest radiographs. And what they found was essentially that there was a systematic underdiagnosis bias for patients that were underrepresented in the data set. So essentially, marginalized patients or patients who have less access to care were less seen in the data set that trained the model in the first place. So the model had a very hard time predicting accurately what was going to happen for those patients. They essentially, when they looked at that, the false positive rates for this model, what they found was that the model failed for women, for younger patients, for black patients, and for patients on Medicaid. When they did the inverse of that, it showed the exact inverse relationship, which shows that the model is selecting on these variables and putting them in this particular order, which again, this was a model that was supposed to kind of diagnose pathology on chest x-rays. So we're talking about sarcoid, pneumonia, things like that being missed. So when we talk about the consequences of bias, we know that it can lead to a decrease or harmed patient-provider relationship and decreased trust. It can lead to entrenched discrimination, very offensive terms. It can lead to an inaccurate clinical picture. It can lead to increased costs and missed or underdiagnosis. So when we start to try and mitigate this bias, right, what this means is that we have to do this, again, at every step. So when we're talking about the real world, well, I talked about the problem of documentation bias. So let's go back to that. This is a study by Mayor Catherine Beach of Johns Hopkins University that looks at, we're gonna call it negative descriptors. So we at Mount Sinai Hospital, as part of a fair documentation work group, have put together a group that want to try and understand these bias terminologies and how do we get them out of the EMR. It's a big group, including stakeholders, so patients, nurses, social workers, data scientists like myself, physicians, everyone's at the table. And while our task is straightforward, we wanted to essentially evaluate for bias in the chart and then take it out. That's a pretty labor-intensive, hard task to do. And so what we wanted to do is develop a natural language process or pathway as well as any other kind of AI-based solutions to try and help do this. So the overview of the project looks like this. Essentially, we created a work group. We looked through the literature for negative candidate or descriptors. We also brought in our patients and social workers, our other advocates for our stakeholders and had them supply what they thought would be negative descriptor candidates. And then we voted on these multiple rounds till we got consensus with everyone that was there. And we decided on what we called 19 never words, words that should never appear in the chart under any circumstance. So things like frequent flyer, illegal immigrant, argumentative, drug seeking, things that just we think there's no tolerance for that. We then essentially got some human reviewers to start to see if they could all agree on what these bias terms were, and we were satisfied with anything over 0.6 in their inter-rater reliability, so we had gotten to moderate agreement. When we compared our reviewers with the actual NLP model, it was nearly 100% except for the word claimed, which has other meanings in the EMR, which are unbiased. So we then turned that model loose on our population to see, well, are these words showing up in the chart? And surprise, surprise, they were. This does seem to be at a low percentage. We looked at, I think, around 800,000 charts. So when you're seeing like 0.2%, these numbers are turning into kind of hundreds, multiples of tens, and we said that we didn't want to see them ever. Okay, so they are showing up, and they're showing up with frequency. When we looked at who was the biggest offender, well, shocking, it was actually the physicians. So we've now put together a plan of not just looking at never words, but also descriptors that, negative descriptors that can kind of capture not just bias in what we've already defined, but new evolving bias. Language changes and it's not stagnant, so we didn't want to be either. And you might be thinking, what does a negative descriptor look like? So here are some examples, and then some affirming options to actually supplement that words or change out kind of our language and our thinking. And this project is actually part of a big education initiative too, but it goes to show that AI can also be part of the problem and some part of the solution. And we'll keep on that theme. I want to show you this study, which is probably the one that was most shocking so far. They were actually able to ameliorate some of the effects of the data training simply by adding in a positive word positive adjective prior to the sentence completion. So we remember how this looked. Well, when they added positive words, when they added just any positive word, you can see the original here, the first bars, when they added just any positive word, we had almost a 33% reduction. When we kept it just to the first 6 most positive words, we actually got a reduction that brought it to within the margin of error for Christians, which was the reference group in this particular case. So what we're seeing here is that even if a model is biased, has bias training data, we can change it once we know that the bias is there. But we do have to recognize it in order to start trying to take those actions. This is a study by Adam et al. That was published in 2022, which basically gave a fictional health emergency crisis where they varied the race and religion of the individual in the crisis, and they asked the participants to assess essentially a method of action, whether they were going to call the police or call for EMS. And then they changed the AI recommendation. So the AI could be biased or unbiased and provide either a prescriptive recommendation or descriptive recommendation. And what they found is, broad strokes, is that the overall baseline clinicians and non-clinicians were not biased. When they were just not given any kind of bias in that readout, they overwhelmingly called for EMS assistance. When they were given a biased a biased AI, they now started to act in a biased manner. What was interesting was that if the EMR was, instead of giving prescriptive language, gave descriptive language, well, the bias all of a sudden disappeared. So what this tells us is that AI can lead us down the rabbit hole, but if we're using the AI to just give us descriptive language, factual accounts of what happened, well then we'll actually kind of right the ship and we'll go back to being less biased. So AI, by its definition, is it's going to be helping us in this way. It can't be prescriptive. It can't be editorializing. It can't have opinion words in it. And last but not least, this was a study that looked at, okay, so we have a model. It is being biased. How do we go out and fix it? And this was in a model called aequity. They oversample when they know that they have an undersampled group for specific metrics to fill in those gaps in the model. And then what they're hoping to do is when you start with essentially a discrepancy like this, through the oversampling, bring the bias metrics basically in line with each other. So we're eliminating that bias by oversampling data, okay? And what they're able to show is for a vast amount of pathologies and demographic groups that they actually, if you pay attention to bias, go and look for the right information to supplement it and then rerun or retrain those studies, we can actually get rid of that bias. So putting this all together, we're gonna come back to those questions. So when we're talking about bias in the real world, we have to question, again, who are the stakeholders, who is this AI designed to help, and who actually conceived of it? Were all the people at the table that needed to be there? If so, then it's okay. If not, then we might want to think about how that biases the model. When we're talking about the real world, about data, we want to talk about whether it's complete, whether it's accurate, and how we handled it. The AI model has been tested in many situations, whether it's been externally validated. And then last but not least, whether or not we can actually understand what's coming out of the AI. Is this a black box or is it transparent? And if I need to override it, can I do that? Right? So we're gonna come back to this call to action for emergency physicians. This is another picture done by AI with the prompt, "The Future of AI in Emergency Medicine." And while I think this is interesting, I don't necessarily know that we need 2 robots and all these screens. What we need, essentially, are a bunch of physicians who are invested in making small incremental changes to make things better, okay? And I think all of you have the ability to do that, but AI is gonna be complex and it's gonna bring a lot of challenges. But if we're proactive in it and we start to think about these ethical considerations and put in place systems to address them, well, what we'll have is the ability to truly change and affect not only the care of our patients, but really the specialty going forward, okay? And with that, I'll leave you with a quote from Maya Angelou, which is, "Prejudice is a burden that confuses the past, threatens the future, and renders the present inaccessible." And I'd like to take my mentorship theme and open the floor to questions. Thank you. Dr. Pillow.
Thank you very much. So I had a question as you're going. The study specifically with the chest x-ray, was it that a chest x-ray with a finding was being called pneumonia if they were white and wasn't if they were black? Or was it that the model didn't have enough sarcoid to recognize sarcoid, which is more prominent in black?
Correct. So it was the latter. So the model did not have enough positive examples of sarcoid to reliably recognize sarcoid. So it would give false negatives in those cases when it was a positive. And when they went back and trained the model to then again look for these specific pathologies and ran it again, lo and behold, it didn't do that. But it was just because they didn't think about that. They're like, well, we probably have enough. We have enough to power it, so let's see how it goes. And then they didn't, go back and test it on that population to see how it worked.
So, DJ, great presentation. Just quickly, so you mentioned that someone has to look for the bias. Who is that person who looks for their bias? Is there an agency that has to be created and that all these algorithms has to be run through? Like, so they can actually determine that? Because I don't think people who write this stuff or who do this necessarily are thinking about that.
I think they are more and more, but as if there is no overarching organization that looks at bias. In fact, you can get into kind of a fractured landscape as to who is controlling what when we talk about things as simple as like medical devices, right? So it's like the FDA has say over that. But when we're talking about language or models, mechanisms, no, there's no oversight. And so this is why I think it's a very important thing for kind of us as physicians to educate ourselves and start asking those questions so that when you see claims that seem a little bit too outlandish or really like, wow, that's impressive, let me go and check. These are 4 questions very quickly that will kind of unearth very, very obvious bias that needs to be addressed.
This is a personal interest as a daddy for me. So that list of words you presented were never words. Some of them were very intuitively never to me. And some of them were just words that have simply garnered a connotation.
Sure.
Right? Like,
yeah.
For example, I used to do do research, I advocate, I work with sickle cell patients. I say sickler may be different than someone else says sickler. That's one that jumped out at me. And then the other one was a diabetic patient. Like,
So those are actually the same, oh, sorry guys. Those are actually the same issue, which is that we don't want to refer to a patient as their condition, right? And overwhelmingly, interestingly enough, not something that I think has been studied, but I pick up kind of on my own, is that we generally only do that with conditions that are targeted towards African Americans, right? Asthmatics, diabetics, sicklers, right? Like, you know. Well, no, so I mean, turning the pathology into the patient is what I'm saying. Like that is, so that specifically is a rule that our committee kind of came together and said, we're not looking to do that anymore. So I wouldn't say that this is biased, again, across the board, but this is our community's definition of bias that we came together and agreed, which is why it works for us.
No, I like that, and that's what I was trying to determine, like, how do you, I remember very poignantly, a very well-meaning physician who did mission work in Puerto Rico and other places, spoke fluent Spanish, white woman, fluent Spanish, really cared for our population at Ben Taub in Houston. She felt that she should be able to say Hispanic panic because she genuinely cared. Yeah. Right? And it gets into this, well, what's a definition of, and I like this, and I was just asking like how you chose that. So it was the modified Delphi consensus where we all had to agree on it. We separated the words into 4 classes. Essentially, one was never word. The other ones were sometimes words, essentially words that either needed explanation, were medically okay, but again, we were going to need to kind of bring up the patient's education level up to. And then words that we were like, well, we're not sure, we'll come back to that. We then chose to stick with the never words for kind of content analysis because those were the most kind of likely to have that negative bias. But I think to to say what you were saying about Hispanic panic, right? And this is completely out of left field, but you know, when Chappelle left kind of the Chappelle show in the late 2007s, right? He didn't do it because you know, he was getting tired or he was busy. What he was thinking is like, I'm putting out a product that, yes, I understand this culture and I care about this culture and this is funny to me, it speaks to my people, but when other people consume this, who are not of this culture, right? I no longer control how they react to it. I no longer control what they do. And so when he saw people out there on the streets talking about, you know, I'm Rick James or doing other things, portraying black people in a way that he wasn't comfortable with, knowing that he had given the ammunition for it, he was like, I don't really need to do that. Walked away from the show, right? So I would say, is saying the word Hispanic panic so important to you that you can't understand that someone else may see you say that, not understand your attachment and your love and the dedication that goes when you're saying that, and just start to emulate it, and then we start perpetuating it. And I would say that risk is probably not worth saying the word.
And so how do you said that emergency physicians should be the ones, you know, changing this? Like, how do we do that on a practical level?
How do we change bias on a practical level?
Yeah, I mean, apart from, you know, individual interactions on a day-to-day basis, you know.
So I think you started off with kind of like, how do we get people to change their thought process in pain, right? And I think it's going to be a very similar process. It's not going to happen overnight. We're all going to have to do it together. But I think it's very important that we all take a little bit of interest. You don't need to be an SAEM presenting on AI, but a little bit of interest when you're seeing AI starting to get applied in your department for actual outcomes, right? Like it's now going to be choosing between someone for helping, changing someone's life. We need to understand how that was built. We need to understand who it was built for and why it's saying the things that it says, right? And all of us need to figure that out when that's happening in real time, right? So you can start now by like just, you know, taking some studies here and there, looking at them, approaching them kind of like critically. But if we don't do this, what's going to happen is the day's going to come when they roll out AI to our EDs, and undoubtedly it'll be made by someone who knows way less emergency medicine than we do. Okay.
Sorry, this is just a aside. Like, I think it would be ideal, or like the pie in the sky idea, you know, 20 years from now, if you know how when you're writing a word and then you're misspelling it and it tells you like underline, like you're misspelling it, like if we get to a point where it identifies these words but you're no longer even putting them in the chart, and it would tell you like grammatically it's incorrect, or
Yeah.
you're introducing bias as you're even putting it into the chart. Because like the models you're saying like it's junk in, junk out. Well, if we could stop putting junk in, then we wouldn't have to rely on it always, like someone catching those instances, the machine would correct itself over, it would teach itself how to correct itself over time.
Absolutely, and I don't know if I'm giving away too much here, but Epic actively working on that right now. The reason why we decided to continue with our project in the way that we're doing it is because even if you change, let's say you autocorrect the word, the person's never really learning why that word wasn't supposed to go there. I'm sure you could have mouse overs, pop-ups. People hate pop-ups, and there's no sure way to have them kill that program to have it pop up and interrupt their work, right? But if you change kind of the practice and the beliefs behind it with an education campaign, and then also pair it with what you're just saying, right? That kind of informatics approach to go and basically autocorrect, right? The two of them over time, now you're changing people's minds, you're also changing the words. Now hopefully that can be a little bit more effective, but I agree with you wholeheartedly. If you're training a model, again, just like the ChatGPT, right? Like you're training it from data that has that bias, that's going to be really hard to kind of eliminate that bias.
Great.
Thank you.